Hello and welcome to our attendees here in the U.S. and around the world. Thank you for joining us for today's Nova Biomedical webinar, Early Blood Glucose Screening in Asymptomatic High-Risk Neonates. Our speaker today is Dr. Nazih Hanna, Chief of Neonatology at NYU Langone Hospital and Professor of Pediatrics at the Long Island School of Medicine. We'll also hear about the impact of accurate neonatal point-of-care glucose testing from Dr. Dennis Begos of Nova's Medical and Scientific Affairs Department. I'm Rick Rollins, Director of Marketing at Nova, and I'll be moderating today's event. To take part in the discussion, you can post questions during the webinar using the Ask a Question tab on your webinar console. We'll address questions following the main presentation and provide a full list of questions and answers soon after the webcast. This webinar has been approved for 1 contact hour of PACE continuing education credit and 1 CERP unit by the American Association of Critical Care Nurses. You can obtain your CE certificate by completing the post-webinar survey that will be sent following the conclusion of the webinar. If you fail to receive the survey, please be sure to check your junk mail folders and your email system. Also note that on-demand viewing credits are available for only 1 year after the initial airing of this webinar. You can register for future events on the Nova website and explore our extensive library of on-demand content, with topics ranging from clinical and veterinary diagnostic testing to biotech and pharmaceutical cell culture testing. Be sure to subscribe to receive notice of future Nova educational webinars. You can also find more information about whole blood critical care testing products on the Nova website. And now on to our main presentation. As Chief of Neonatology at NYU Langone Hospital in Long Island, Dr. Nazih Hanna leads a research program that has special expertise in the areas of reproductive immunology, which studies the maternal immune system to understand various triggers that lead to preterm delivery. His team is also actively researching the role of breast milk in improving newborn health, as well as developing innovative methods to diagnose and treat swallowing problems in newborns. Dr. Hanna states that as a neonatologist who cares for newborns, he has learned that a person is a person, no matter how small, and he's honored to help babies born early or with medical conditions develop into healthy children and adults. Please welcome Dr. Hanna.
Thank you, Rick, for your kind introduction. My name is Nazih Hanna. I am the Chief of Neonatology at NYU Langone Hospital and Professor of Pediatrics. I'm truly honored to speak with you today about a very important topic in neonatology. The title of the talk, The Critical Hour, Why Early Glucose Screening in High-Risk Neonates is Essential.
So why hypoglycemia is critical in neonates? Glucose serves as the primary energy substrate for both the fetus and the newborn. During pregnancy, the fetus receives continuous supply of glucose from the mom through the placenta. Well, after birth, the supply stops and the neonate must rely on their own glucose production through glycogen storage in the liver, which might not be sufficient initially. Postnatal adaptation to extrauterine life involve an initial decline in plasma glucose during the first few hours, followed by activation of counter-regulatory mechanisms such as glucagon and catecholamines, which promote glyconeogenesis and glycogenolysis to restore glucose levels. Disruption with this homeostasis might lead to neonatal hypoglycemia. Because glucose is the main energy source for the brain, severe hypoglycemia can cause permanent brain injury. Alternative substrate like ketones and lactate are insufficient to provide neuroprotection during early and severe hypoglycemia. The risk of neurological damage increases with decreasing blood glucose levels, regardless of the presence or absence of signs and symptoms of neonatal hypoglycemia. So you can't assume that no symptoms or sign mean the brain is safe. Almost 80% of hypoglycemic infants will show no clinical signs. So definition of hypoglycemia, which remains controversial due to the lack of universal accepted blood glucose threshold levels. The American Academy of Pediatrics guidelines suggest maintaining blood glucose more than 40 milligram per deciliter in the first 4 hours and more than 45 milligram per deciliter between 4 to 24 hours after birth. The Royal College of Pediatrics and Child Health defined hypoglycemia as less than 36 milligram per deciliter in full-term neonates. However, defining hypoglycemia within the first hour after birth is not well established. Low blood glucose levels can cause neurological complication in severe, prolonged, or recurrent hypoglycemia episode, regardless of symptoms. So what's the incidence of hypoglycemia? Approximately 15% of neonates exhibit hypoglycemia in the first few days of life, with a higher prevalence in at-risk neonates, including delayed preterm, LPT, small for gestational age, SGA, large for gestational age, LGA, and infant of diabetic mom, IDM. So the incidence of early neonatal hypoglycemia in the first hour after birth and its possible sequelae are unknown. There is limited data available on the optimal timing of glucose screening in asymptomatic neonates who are at risk of developing hypoglycemia. The Committee on Fetus and Newborn, part of the AAP, published guidelines in 2011 for the screening and management of hypoglycemia in high-risk neonates. And we're going to focus on the first 4 hours in asymptomatic infants. As illustrated in this slide, the AAP would recommend initiating feeding within 1 hour in this high-risk population, and then screen for glucose 30 minutes after the first feed. And if the initial screen is less than 25, they would feed and give as well dextrose gel and recheck in 1 hour. If it's less than 25, they suggest giving IV glucose. For level between 25 and 40, they suggest refeeding or IV glucose as needed. However, other studies suggest that waiting until the level drop to 25 is too risky, since there is a higher risk of neurosensory impairment with these low levels. In this study on the screen, suggested a balanced approach to managing low blood glucose sugar in newborn. They suggest intervention at level below 47 milligram per deciliter might not be needed, but waiting until level drop below 25 is too dangerous. They strongly recommend starting treatment when levels is below 36 milligram per deciliters. In our unit at NYU, we treat with feeding and dextrose gel for level less than 45 and IV glucose for level less than 25. So back to the AAP recommendation. Again, according to the AAP, the time frame for the first blood glucose measurement will be around roughly 1.5 hours to 2 hours. Again, taking into account that they wait an hour or so to feed and then feed the baby and then wait 30 minutes and get serum glucose. So roughly it will be around 1.5 to 2 hours, but that will be substantially higher with exclusive breastfeeding, especially after cesarean section. So I guess the question is waiting 2 hours before we get the first glucose screening in high-risk neonates is safe? So there is significant gap in knowledge regarding how early we should screen high-risk neonates. Before I present to you our study, I want to tell you why we actually did it. So a few years ago, we had a case where there is a high-risk LGA baby who developed seizures at 45 minutes of life with a very low blood glucose level. Had a very poor outcome and significant pathology on MRI. When we reviewed the case, we concluded that there was no chance to save this child with the current AAP recommendation. So we decided to do a study to determine the instance of early critical hypoglycemia in the first hour of life in high-risk neonates. So we did this study, which was recently published last July. And the investigator team includes Dr. Al-Kawam, Dr. Dumpa, Dr. Islam, and Dr. Khan, and beside myself as well. The aim of the study is to investigate the incidence of early severe neonatal hypoglycemia within the first hour of life in asymptomatic high-risk neonates that may have gone undetected under the current AAEP recommendation. Additionally, we explored the relative impact of each risk factor on the development of early hypoglycemia in this high-risk neonates. So go to the study design. So it was 2-year prospective cohort study involving 9,919 births. Of them, 1,690 were defined as high-risk neonates, including SGA, LGA, IDM, and late preterm infants. StatStrip glucose meter was used as a point of care to measure blood glucose levels at 30 minutes of life. Early hypoglycemia was defined as less than 25 milligram per deciliters. We had 52 babies, or 3.1%, with blood glucose less than 25, which were admitted to the NICU for further management. Out of these 52 neonates, 8, or 0.5%, had blood glucose less than 10 milligram per deciliter, which basically below detection level. 7 had blood glucose between 11 and 15, and 37 had blood glucose between 16 to 25 milligram per deciliter. Infant with blood glucose more than 25 continued to be screened per AAP guidelines, with hypoglycemia defined as blood glucose less than 40 for the first 4 hours or less than 45 between 40 to 24 hours. So we had in this group 47 babies with blood glucose between 26 to 40 and 1,591 with blood glucose more than 40 milligram per deciliters. Some of these infants developed delayed hypoglycemia treated with feeding or dextrose gel and admitted to the NICU if treatment failed, needing IV fluid. So 27 out of the 47 in the blood glucose of the 26 to 40 and 34 out of the 1,591 in the blood glucose level more than 40 were admitted to the NICU for further management. You can see here the TA is the time to admission, defined as the average time from delivery to the NICU admission. So regarding the NICU length of stay, LOS, it was proportional to the degree of hypoglycemia, both in early and delayed hypoglycemia groups. This table showed the prevalence of various risk factors in the 52 neonates with blood glucose less than 25 detected during early screening in the first hour of life. There were 17 neonates who had multiple risk factors, 2 or 3 risk factors. Since a single newborn can have more than one risk factor, the parentheses in the table indicate the number of neonates with multiple risk factors, including the specific risk factors. For example, out of 52 neonates with early hypoglycemia, there were 31 late preterm neonates. However, 18 neonates were LPT, late preterm, as the only risk factors, and 13 had other risk factors beside LPT. Most neonates with very low blood glucose level, less than 10 or undetectable, all the way to the right, had multiple risk factors, highlighting the increased risk of critical hypoglycemia with multiple risk factors. Another question we had was which risk factor contributes most to the severe early hypoglycemia? So we performed univariate logistic regression model to evaluate the relative importance of each risk factor in the development of early hypoglycemia, here defined as less than 25 milligram per deciliter. So for late preterm, there were 31 LPT neonates who developed early hypoglycemia and 360 neonates, LPT neonates who did not. So incidence of 8.6%. In other words, 8.6% of late preterm infant will develop hypoglycemia. Now, if we took the LPT infant out of this cohort, the incidence of hypoglycemia drops to 1.6%, and the p-value here is less than 0.1. This indicates that significant contribution of LPT to hypoglycemia risk in this high-risk group. LGA as well was a major contributor to hypoglycemia. However, IDM and SGA was not a significant contributor to hypoglycemia in this cohort. Similar results were observed for blood glucose less than 15. And as you can see, the main contributing factor for hypoglycemia were LPT and LGA. We did not do the same with level less than 10 because we had very low number for this cohort. So for the results, in asymptomatic neonates at risk of hypoglycemia, the incidence of severe early hypoglycemia is not uncommon. The severity of early hypoglycemia correlates with the increased length of stay. Results of the present study highlight the importance of close monitoring and prompt screening of asymptomatic at-risk neonates. Late preterm and large for gestational age infants are at the highest risk of early severe hypoglycemia and might benefit from selectively early blood glucose screening in the first hour of life. So another way to look at the results. So what is the number of babies you need to screen to detect early hypoglycemia? For glucose less than 25 milligram per deciliters, number needed to screen is 33. This is a cohort in general. However, for LPT, it's only 12. For LGA is 18. Those are the number for detection of glucose less than 15. And for the most severe one, which is undetected level of glucose, the number need to screen is 200. However, for LPT is 53, and for LGA is 101. So clearly, if you don't want to screen all high-risk neonates, you cannot afford to miss the LPT and LGA groups. So question is early blood glucose screening in the first hour of life is indicated for high-risk neonates? To give you perspective of screening tests in neonates, there are several criteria for effective screening tests in neonates. First one is criteria is the incidence threshold. So typically, condition with incidence of more than 1 in 10,000 live birth are considered for screening. Example of that, we do that already. Congenital hypothyroidism, the incidence is 1 in 2,000 to 4,000. Newborn metabolic screening, 1 in 4,000 to 10,000. Hearing loss, 1 to 3 per 1,000. And again, for hypoglycemia, early hypoglycemia in this group is again much higher than that. It is either 3%, 3 in 100, or for the severe one, which is undetected, is 5 in 1,000. So definitely meet this criteria. Second criteria, severity of the disease. Disease that cause significant morbidity, mortality, or long-term disability. I think severe hypoglycemia qualify for that as well. Effectiveness of screening and treatment. The screening test should have high sensitivity and specificity. Early treatment must significantly improve outcomes. And again, that is true for early hypoglycemia. Cost effectiveness. The cost of screening and intervention must be reasonable compared to the benefits of early detection. And again, using a glucometer is pretty cost effective. So early hypoglycemia screening fits all these criteria and should be done. And this has been implemented at our NYU system. As I present this information to others, I frequently receive some questions that I would like to address. So one of those questions, could this be transitional early hypoglycemia, basically physiologic nadir? So before we answer this question, let us review the evidence we have. This is a study published in 2020. The study enrolled 67 healthy term neonates and measured blood glucose in the first 120 hours by two methods, either glucometer, which is the top graph, and continuous glucose monitoring, which is the bottom graph. The x-axis is the age in hours, and the y-axis is the blood glucose levels. So the first interstitial glucose concentration were obtained at a range of approximately 1 to 11 hours. As you can see in the graph, that the 10th percentile for blood glucose was approximately 2 millimoles per liter, which is around 36 milligram per deciliters, and there was no levels less than 10 observed in this cohort of healthy term infants. It's another study published in 2017 where they enrolled 519 healthy term neonates born by cesarean section and screened for blood glucose levels on admission using StatStrip glucometer, which is the same what we use in our study. The x-axis is the age in minutes, and the y-axis is the glucose levels. As demonstrated here, there are very few levels detected below 30 and none below 20. The authors wrote in their conclusion, we propose setting blood glucose cutoffs for the use in healthy term neonates. For hypoglycemia cutoff is blood glucose less than 5th percentile, which is 35 milligram per deciliter. For intervention hypoglycemia, meaning that we need to intervene if the blood glucose is less than the 1st percentile, which is 30 milligram per deciliters. So in conclusion of those studies, so our study suggested that at least there is 0.5% of high-risk neonates will have undetectable blood glucose levels. So suggesting that a glucose level below the detection level in the first hour of life is a physiological nadir is not supported by current data and definitely is highly risky. Another question, we don't know if transitional hypoglycemia in the first hour of life will be associated with poor neurodevelopmental outcomes. And that's a valid point, as no study have been conducted to demonstrate poor neurodevelopmental outcome associated with hypoglycemia in the first hour of life. However, conducting such study would be highly unlikely, of course, due to the ethical challenges of withholding treatment for critical low glucose levels for research purpose. So it's very unlikely such research will be done. However, there was a study published in JAMA Pediatrics, and the aim for the study was to determine if early initial low glucose concentration within the first 3 hours of life is associated with subsequent poor academic performance. The median time to specimen collection was 30 minutes. The author concluded that early single, just one level of transient newborn hypoglycemia less than 35 was associated with lower achievement test scores at age of 10 years. So again, to conclude this part, there is substantial evidence linking hypoglycemia within the first few hours of life with adverse neurodevelopmental outcomes. So the AEP recommend immediate intervention for hypoglycemia less than 25 milligram per deciliter at 1.5 hours of life to prevent poor neurological outcomes. So there is really no reason to believe that hypoglycemia at 30 minutes would be any less harmful, especially for a level which is undetectable. Waiting until 1.5 hours or more, based on the AEP guidelines, to check blood glucose in such vulnerable infants could mean missing an early and a critical window to address hypoglycemia before it potentially affects the neurodevelopment of those high-risk neonates. Another feedback question, that such screening might disrupt breastfeeding, separation from the mom, etc. So at least in our institution, blood glucose checks occurred while the baby was with the mom, skin to skin, and it was performed as the mom is holding the baby. Our institution is designated as a baby-friendly facility. So early screening in the first hour of life did not cause breastfeeding disruption or separation from the mom. So our recommendations, it is crucial to screen high-risk neonates, regardless of symptoms, within the first hour of life to detect early critical hypoglycemia, particularly in neonates who are LPT, late preterm, LGA, or with multiple risk factors.
So thank you so much for joining and listening about neonatal hypoglycemia. Back to you, Rick.
Thank you, Dr. Hanna. Your research certainly emphasizes the need for early glucose screening in high-risk neonates. Next, Dr. Dennis Bagos will discuss the impact of accurate neonatal point-of-care glucose testing. Dennis?
Thank you, Rick, and I wanted to especially thank Dr. Hanna for agreeing to present on neonatal hypoglycemia and its diagnosis and management. We're really fortunate to have him speak on this and share his expertise and share his research with us. And what I wanted to talk about today is more focusing on the use of point-of-care technology to diagnose and manage neonatal hypoglycemia, and share some data in addition to Dr. Hanna's data that supports the use of point-of-care testing in this situation. Just to review the benefits of point-of-care testing, there are several. First of all, it's convenient. It can be used at home, and it's used at home by many people. It can be used outside of the hospital in pharmacies or clinics. It's generally faster than getting results from a laboratory. There's data that shows that patients have increased compliance, particularly if they are using point-of-care testing to measure HbA1c in diabetics or lipid testing in patients being treated for hypercholesterolemia. There's some evidence that it provides an increased safety window, particularly in radiology, where patients might be getting contrast studies. It's used at home quite a bit, obviously, for diabetic patients managing their insulin dosing. And it requires lower blood volume than traditional laboratory testing typically. And as I mentioned before, it can be available in remote areas. So in particular, regarding neonatal management, the speed is important. It often takes an hour or more for a glucose result to come back from a central hospital laboratory, and results from the glucose meter are typically back within a few seconds. And the lower blood volume is also of critical importance in managing neonatal patients. There are some potential drawbacks of point-of-care testing. So with any test, there are errors that can creep in, and we can divide these into pre-analytical errors, which can be a user error, and making devices easier to use is key to avoiding those. Pre-analytical errors are less common than with central lab, where blood sometimes can sit for a while before it's processed. There can be environmental factors, which typically aren't an issue in developed countries, such as high altitude or temperature, where there's not good climate control inside a hospital. And errors can also be related to the device, whether it's not maintained properly or not calibrated properly prior to testing. One of the more critical drawbacks of point-of-care testing, particularly with certain blood glucose devices, are interferences. So sugars can interfere with glucose, and you can see here a list of some of the sugars: maltose, galactose, xylose, and icodextrin, which can be falsely read as glucose and give a falsely elevated result. Various drugs, such as dopamine, acetaminophen, and ascorbic acid, can interfere with glucose measurement. And then there's endogenous interferences, particularly hematocrit, which is important in the neonatal setting, that can interfere with glucose measurement. And you can see those highlighted right here. Infants and neonates can often have disordered metabolism that causes increased galactose in their blood. And again, this can be falsely read as glucose by certain meters. And infants also have a very high hematocrit at times, and this can cause interference with glucose measurement. In adult patients in the hospital, typically they would have a lower hematocrit, which again can also cause errors in glucose measurement. And the reason why hematocrit can cause an error in glucose measurement is that when we measure glucose in the lab, the blood is spun down and we're measuring the glucose in plasma. When we're measuring it with a glucose meter, we're using whole blood. And so the meter has to do a conversion from what the hematocrit is to convert it to the plasma value. This is fine if the hematocrit is normal. However, in patients with a low hematocrit, they can often have a lower reading if the hematocrit is assumed to be normal, and patients with a high hematocrit can have a higher glucose reading or a falsely elevated glucose reading due to the high hematocrit. Many glucometers simply assume that the hematocrit of the patient is normal. The Nova StatStrip glucometer will measure the hematocrit and give an exact conversion factor for what the plasma glucose actually is. And these are just some studies looking at the Nova meter compared with some other meters and compared with the central lab glucose measurement. You can see the Nova meter is highlighted in the red box, and there's really very little variation across the spectrum of hematocrit from 20% to 70%, while other meters will have significant deviations from the central lab glucose based on the hematocrit level. Neonates in particular, it's important to have accurate glucose measurement. They can have more rapid changes in their glucose and in their clinical status. Hypoglycemia is very common in neonates due to a variety of reasons, including less or no glycogen storage. Their gluconeogenesis pathway can take a while to mature and replete low glucose levels. They often have low caloric intake, and there can be metabolic disorders that lead to hypoglycemia. In addition, because neonates obviously can't necessarily tell you that they're having symptoms of hypoglycemia, the diagnosis of hypoglycemia rests entirely on laboratory studies. Physical exam may not be accurate, and issues may be asymptomatic, and thus hypoglycemia can be missed if lab testing is not done and if lab testing is not accurate. And obviously, neonates are very susceptible to hypoglycemia in terms of issues with neurologic development. So here are some studies that have looked at the Nova StatStrip glucose meter in various settings. This first study is an analytic benchtop study that was done using neonatal samples in China. They followed a rigorous 3-step process for validating and checking the accuracy of the meters. And they used 2 meters. They compared the StatStrip meter with a Roche Accucheck meter. And they followed the standard CLSI POCT 12-A3 standard, which is the current standard for validation of glucose meters. So what they found, you can see the bias on the left between the StatStrip meter and the central laboratory meter, and this is represented in a Parkes error grid, where measurements that are inside the lines that you see there represent a bias that is of no clinical significance, and ones that are just outside the lines, like you see a very few of them there, represent minimal clinical significance. So the meter had excellent correlation with the laboratory reference method. And the conclusion of the authors, they said that the clinical performance of the Nova StatStrip blood glucose monitoring system in neonates met the system accuracy criteria of Clinical and Laboratory Standards Institute POCT 12-A3 standard for evaluating hospital BGMS. StatStrip BGMS achieved analytical and clinical performance criteria, confirming its suitability for use in neonates. And this was not true for the Roche meter in this study. Another factor that they studied in this paper was interferences, and you can see here several common interference measurements that they used. The 2 panels on the right show hematocrit interference with glucose measurement, and the top box shows the Nova meter, which has virtually no deviation from the central lab measurement based on hematocrit, whereas the meter on the bottom, which was the Roche meter, does show significant decrease in glucose levels as hematocrit levels go up. Other interferences such as ascorbic acid, lactose, galactose, and glutathione also showed significant deviation in glucose measurement on the Roche meter, but not on the Nova meter. Another study was done out of Toronto, and this was at Sick Children Hospital in Toronto, where they had changed their blood glucose meters from a LifeScan product to the Nova StatStrip. And they retrospectively looked at management and accuracy of the blood glucose measurements in neonates prior to the changeover and then after the changeover. So they compared the old system, the LifeScan system, to the Nova StatStrip. And what they did was they looked at infants who had a heel stick blood glucose measurement within 20 minutes of a central lab measurement. So it was a retrospective study, but it was a reasonably large study with 651 patients. And you can see on the table on the right that the patients were pretty evenly matched in terms of their demographics. And you can see here some of the results. In the correlation on the left, you can see the Nova device matched or had a 99.8% correlation with the central lab, which is obviously very good. And then the ROC table on the right showed that the Nova StatStrip had 98% area under the curve accuracy for diagnosing hypoglycemia, particularly if a level of 3.7 millimoles per liter was used. And this was statistically significantly better than the previous product that they were using. They also looked at interferences and again found significant problems with interferences with the prior meter that they were using, and there was no evidence of any hematocrit interference with the Nova meter. The previous meter also showed significant interferences with beta-hydroxybutyrate, ascorbic acid, and L-DOPA, while the Nova meter showed no significant interferences across the whole panel of measurements that they did. Some of the conclusions that they arrived at based on this study is that the Nova meter had increased sensitivity for hypoglycemia detection. They found a much lower false negative rate and improved ability to rule out neonates that were not at risk for hypoglycemia. There was a threefold reduction in false positive measurements. They found that they were better at identifying neonates at risk for hypoglycemia. They actually observed lower mortality rates during this portion of the study, and there were fewer downstream requirements such as endocrinology consultations that were obtained since using the Nova meter. And one thing that they uncovered during the study or discovered is that they actually had a lower meter utilization since implementing the Nova meter, which this was somewhat of an unexpected finding. So you can see here on the graphs on the left and the right that there was decreased meter utilization, both total meter utilization and utilization for critical results since they implemented the Nova system. And the authors concluded that when we reanalyzed the data as a proportion of total BGMS glucose measurements within each of the three cutoffs, significant differences were observed between both meters. This strengthens the argument that differences are attributable to the improvements in analytical performance of the StatStrip rather than to decreased prevalence of results. Improved accuracy of StatStrip could explain the need for less frequent testing and more operational confidence by NICU users, which could ultimately contribute to tighter glycemic control. So basically, having more confidence in the Nova meter system led to fewer double checks of results that they thought might be erroneous. Another study out of Maine Medical Center, published in 2019, looked at the current meter that they were using across the hospital, but they looked at it specifically in their neonatal population. They were using an Abbott meter, and they retrospectively looked at patients who were under 30 days old, so neonates, and there were 141 of them. And they found a significantly positive bias using the Abbott meter compared to the central laboratory, which would have caused potential underdiagnosis of hypoglycemia in this population. And they concluded that their point-of-care meter had poor sensitivity to hypoglycemia. The meter appeared to have clinically significant error with a bias towards overestimation of glucose in hypoglycemic patients. So if there's one error you want to avoid in this patient population is missing cases of hypoglycemia, which in this case would have happened. And their meter didn't meet the current standards for FDA, which are the CLSI standards or ISO guidelines in this population. So obviously missed hypoglycemia in this population can lead to significant neurologic complications. Spurious hyperglycemia can lead to overtreatment. So if an infant is diagnosed with hypoglycemia and treated with insulin, then they can become hypoglycemic if that hyperglycemia was not an accurate number. And this institution, following this study, switched to the Nova StatStrip glucose meter. So there's currently only one glucose meter that's cleared for use within all patients in all clinical areas of the hospital, including the intensive care unit and including in neonates, and that's the Nova StatStrip meter. This picture that's here on the right is our current Generation 3 meter, which has just been recently released. Other pictures that you may have seen or meters that you may be familiar with are our Generation 2 meter. All other meters that are being used are then considered off-label use when used in critically ill patients, and high complexity testing under the CLIA guidelines when used in critical care settings. How did we achieve this validation from the FDA? Well, this was based largely on this study, which was published in Critical Care Medicine in 2017, looking at almost 1,700 ICU patients across 3 countries. And the ages of the population was from 2 months to 94 years old in 5 ICUs, again, 2 in the USA, 2 in the Netherlands, and 1 in Belgium. Patients had over 250 diagnoses and were on over 8,000 different medications in 144 drug categories. And we basically paired the measurements from the Nova StatStrip to central lab glucose measurements. And venous and arterial samples were both looked at. So sensitivity and specificity were both greater than 95% on the meter. You can see in the graph here on the right that the variation of glucose measurements across the spectrum of glucose from 80 milligrams per deciliter up to about 300 milligrams per deciliter. The variability was less than 2% across the board there. This is a correlation, and this is an expanded Parkes error grid like we saw in a previous slide. And the Parkes error grid, again, breaks down differences between glucose measurements between the central lab and the meter. In zone A of the Parkes error grid, there's considered to be no clinical significance in any differences. Zone B is considered minimal clinical significance. So in this particular study, 99.3% of the results were in zone A, meaning no clinical significance, and the remaining 0.7% were in zone B. As we saw in the earlier study from China, the meter met the CLSI POCT 12A3 standards with 95.4% of the results within 12 milligrams per deciliter in blood glucose is less than 100, and 96.5% within 12 milligrams per deciliter for blood glucose is greater than 100. And again, the Nova StatStrip device is currently the only blood glucose monitoring system approved by the FDA for use in critically ill patients. So to summarize then, it's extremely important to recognize neonates with hypoglycemia. StatStrip is suitable for use in neonates. It's approved for both heel stick and arterial samples in this population. There's no significant positive bias, as can be seen with other meters, and there's no evidence of any interferences causing problems with glucose measurement, and it meets the current CLSI standards for validation of glucose meter systems. So I wanted to thank you again for your attendance here and for your attention. You can submit any questions that you have through the portal, or if you're watching this at a later date, you're welcome to email me at the email address that you see on the screen. I'd like to again thank Dr. Hanna for his expertise, and now I'll turn it back over to Rick to wrap up and ask any questions that you have. Thank you very much again.
Thank you, Dennis. Now, before we begin the question and answer session, just a reminder to submit your questions for Dr. Hanna and Dr. Bagos using the Q&A tab on your webinar console. Also remember that your continuing education credits will be emailed once you complete the post-webinar survey. A link will be sent to you soon after the conclusion of the webinar. Now we'll take a few questions from our audience. Our first question: what is the policy at your facility for confirming a low glucose test? Have you found any bias between the two?
Thank you so much for the question regarding the policy for confirming a low glucometer reading. So in our institution, and again, I believe this is in most institutions as well, we do repeat the glucometer testing if we get low levels. At the same time, we send for serum glucose. In our institution, it takes approximately 45 minutes to get the serum blood glucose back. By the time you get the blood work and you send it to the lab, get the results. So again, in our institution, we act on the glucometer reading. We do not wait for the confirmation from the serum glucose because it takes 45 minutes and it might be way too long to treat hypoglycemia. In our experience, there is diversion between serum glucose and glucometer reading, but that is usually uncommon. So we kind of trust the glucometer reading.
Thank you for that, Dr. Hanna. Now, our next question is, the results of your research show that the highest risk of severe hypoglycemia within the first hour of life was in late preterm and large for gestational age infants. You also noted that the incidence of hypoglycemia in the first hour after birth is unknown. Given that observation, would you advocate for screening of hypoglycemia in all newborns?
Thank you. That's a great question. So again, our result was done only in high-risk neonates. And again, we believe all high-risk neonates should be screened in the first hour of life. However, we really cannot miss those group of LGA and late preterm. Those are definitely the highest risk. We did not confirm in normal newborn babies if this will be needed or not. However, there are other studies that suggest that most of term health neonates would have a normal glucose level, and very few would have a level that qualify as hypoglycemia.
Okay, thank you for that. Our next question is, what do you think of the role of point-of-care testing and screening for neonatal hypoglycemia?
Again, good question, and I think at this point, we don't have many options. So there was a lot of excitement by getting continuous blood glucose monitoring, but again, it's not very feasible at this point. So the best we have right now is point of care using glucometer. Again, as I mentioned before, also sometimes there is diversion between the actual levels that we get through glucometer and the serum glucose. But most of the time, it's accurate. So again, in our institution, we trust that.
Okay, thank you, Dr. Hanna. Our next question is, transferring a neonate to the NICU for hypoglycemia is stressful for the baby and parents, as well as costly in terms of resources. Yet missing hypoglycemia has serious consequences. Where do you feel is a good balance between false negatives and false positives? And how can we minimize these without over-testing?
Well, the answer is not doing it. So that's really the issue. And this is where our study, I think, will have a high impact. Because there's concern separation the baby from the family and the mom and breastfeeding. So there was no testing done. Our study suggested that can be risky, especially in the highest risk group of late preterm and LGA. So the answer is not that we shouldn't be testing it, but I think maybe selective testing for this very high risk group. And glucometer reading is pretty benign and cost-effective. So I think screening is indicated for this high-risk group.
Thanks again, Dr. Hanna. Our next question is, can you discuss the effect of early blood glucose screening on the rate of NICU admissions? One might anticipate an increase due to increased testing. Did your study bear this out?
Interesting question, and a good one. We didn't really address it in details in the discussion, but what we found, I think we did mention in the paper as well, but just very briefly, the rate of admission overall after implementing this testing did not go up. Now, we did this for 2 years now, and we compared our admission for hypoglycemia in these 2 years after screening compared to the previous 5 years. It didn't go up. So the increased testing didn't result in more admission. Matter of fact, I would argue it does decrease length of stay. So if you notice the length of stay, if you can pick up those babies early on and treat them appropriately, not only will have probably much better neurodevelopmental outcome, but also less length of stay. And that's what happened in delayed hypoglycemia in our paper. So the short answer is I don't believe that the screening of this high-risk neonates resulted in more admission. Those babies would have come to the NICU most likely anyway, but probably much later.
Okay, thank you, Dr. Hanna. Those are all the questions we have time for today. So we'll conclude the webinar at this point, but be sure to join us again and invite your colleagues to attend the next Nova Biomedical Educational Webinar. You can register at novabiomedical.com/webinars, where you'll find a full catalog of on-demand webinar offerings. So for Dr. Hanna and Dr. Begos, I want to thank you for your attention and attendance and wish you a great rest of the day.